Hello everyone, I'm Dr. Muhammad Saleh, and today I will be talking about basics of pediatric ECG, and I promise you over the next few minutes you will have a very good information about how to read pediatric ECG. Contents: rhythm, heart rate, the QRS axis, the T axis, and the QRS T angle, intervals, PR, QRS, and QT, the P-wave amplitude and duration, the QRS amplitude and RS ratio, also abnormal Q waves, ST segment, and T wave abnormalities. Let's start by the conduction system. It starts from the SA node in the right atrium, moving to the AV node, then to the bundle of Hess, moving down to the both bundle branches, right and left bundle branches, then to the Purkinje fibers, giving both ventricles. How to place ECG electrodes? We'll start with we have the precordial leads and we have the limb leads. The precordial leads starting from V1. V1 will be in the fourth right intercostal space, just parasternal area. Then we'll go to V2, the left fourth intercostal space, parasternal area. Then we'll go to V4, will be at the area of the apex, will be in the fifth intercostal space, mid-clavicular line. Then V3 will be in between V2 and V4. Then we'll go to V5, which will be at the same level of V4, but in the anterior axillary line. Then V6 will be in the mid-axillary line. Then we have the four limb electrodes, starting from the left lower limb, then the left upper limb, then the right upper limb, then the right lower limb. Sometimes you will have the colors of these electrodes. You'll start from the left lower limb with the green color, moving to the left upper limb or left arm with the yellow color, then to the red color to the right arm. Always remember red to the right, then in the right lower limb with the black color. After placement of these electrodes, we will have 12 lead ECG. We have the 6 limb leads, starting by lead 1, lead 2, and lead 3. Then the augmented leads, which called AVR, AVL, and AVF, provide information about the frontal projection, reflecting superior, inferior, and right to left forces. Then the precordial leads, starting from V1 to V6, and then you can add to them V3R and V4R to the right side of the chest, which will give you more information about the right side of the heart. These are providing information about the horizontal plane, which reflects the forces from right to left and anterior, posterior. And to remember the direction of forces for each limb lead, please remember this diagram. This left hand for the AVL and the right hand for the AVR, so L for left and R for right. Then here lead 1 and the left lower limb for lead 2 and the right lower limb for lead 3, and AVF is directed to downward and in the middle. And to imagine what's the relation between the electrode placement and the heart itself, here you can see the V1 will be placed in this area, and V2 in this area, V3, V4, then V5 and V6. And here you can see the AVL, AVR, and AVF, and here lead 1, lead 2, and lead 3. This is a correlation or the relation between the precordial leads and the limb leads to the heart. And here another section to make you imagine how is the placement in correlation to the heart position. Here is V1, V2, V3, V4, V5, and V6. Here is the waves of the ECG. You can see here the P wave, and here is the PR interval, which starts from the beginning of P wave to the beginning of the QRS complex. Then we have the QRS complex, Q wave is the first negative deflection, and R wave is the first positive deflection, then the S wave is the second negative deflection. Then you have the T wave, then you have the ST segment, which start from the end of S wave to the beginning of T wave. Then you have the QT interval, which start from the beginning of Q wave to the end of T wave. Heart rate is not a fixed number. It's variable and change through life. The average heart rate peaks at the second month of life, then gradually decrease. Resting heart rate 140 beat per minute at birth, then 120 beat per minute at 1 year, then 100 beat per minute at the 5th year of life, then reach the adult range by 10 years of age. Not only the heart rate changing through time, but the ECG as well. So we have some changes between the pediatric ECG and the adult ECG, and here is a comparison. The most remarkable difference is the RV dominance in infants, most noticeable in newborn, and it gradually changes to LV dominance. By 3 years of age, the child's ECG resembles that of a young adult. RV dominance of infants is expressed by right axis deviation, tall R wave in lead AVR and the right precordial leads like V4R, V1 and V2, deep S wave in lead 1 and the left precordial leads V5 and V6 compared with an adult ECG. T wave in V1 is usually negative. Upright T wave in V1 in this age group suggests right ventricular hypertrophy. And here, as you can see, there is 2 ECGs, one for a 1-week-old infant and the second one for a normal young adult. Let's see what we're talking about. Look for lead 1 and the AVF. You can see there is right axis deviation because there is a deep S here, and in the AVF it is positive QRS, as you can see. So this means there is right axis deviation. For the normal young adult, there is a normal axis. Look for lead 1, there is R wave and no deep S wave, and the AVF is as well a positive QRS. For the AVR, you can see tall R wave, which one of the things that's saying there is right axis deviation, right ventricular hypertrophy. Here also in the lead V1, V4R, V1, V2, there is tall R wave, and if you can see here in the normal young adult, the R wave is not tall as in this ECG of the 1-week-old infant. The normal adult ECG demonstrates the QRS axis near plus 60 degrees. QRS forces directed to the left inferiorly and posteriorly, which is manifested by dominant R wave in the left precordial leads and dominant S wave in the right precordial leads, which called the adult RS progression. You have to know this RS progression or R wave progression. This is a normal R wave. It is smallest in V1 and it is tallest or the biggest in V5 and V6. This is a normal progression of R wave. It starts small, then gradually increase in V2, V3, V4, V5 and V6. This is, look for in the picture to the right, this is abnormal R progression, frequently seen after myocardial infarction. Usually you can see this in adults, not in infants or children. The T waves are usually anteriorly oriented, resulting in upright T wave in V2 through V6 and sometimes V1. So usually the T wave following the QRS. If the QRS is positive, the T wave will be positive. If the QRS is negative, the T wave will be negative. This is the rule. Sinus rhythm is the normal rhythm at any age and is characterized by B wave preceding each QRS complex. The normal p-axis is from 0 to 90 degrees. Here you can imagine, or you can see the p wave, normal p wave axis coming from the SA node in this direction. So the direction of a normal p-axis will be in the between the 0 and 90 degrees. P waves must be upright in lead 1 and AVF. Here you can see this is lead 1 and this is AVF, and this is the direction of force, so it is coming to the positive forces of lead 1 and AVF, so it must be upright in lead 1 and AVF, or at least not inverted in these leads. The normal p-axis results in upright p wave in lead 2 and inverted p wave in AVR, because AVR is in this direction, so the p-axis is towards the negative direction of the AVR. In sinus rhythm, the PR interval is regular but does not have to be of a normal interval. The PR interval may be prolonged as seen in sinus rhythm with a first degree AV block. Some atrial or non-sinus rhythm may have a P wave preceding each QRS complex, but they have an abnormal P wave axis, and this is very important. The direction of the P wave should be, as we said, from 0 to 90 degrees. This is a normal axis of P wave. Sometimes you will have this atrial rhythm or non-sinus rhythm. You will have a P wave before each QRS, but what is the direction of this P wave? The axis of P wave is very, very important to differentiate between the sinus rhythm and the non-sinus rhythm. And here you can see the sinus rhythm in this lead 2 P wave axis normal, and it is upright in lead 2 and it is inverted in AVR, and in V1 you can, as you can see, this is a normal sinus rhythm, but here you can see in the lead 2 this P wave, which was upright and positive in lead 2, start to change from a normal sinus rhythm to low atrial rhythm. Look here, the in lead 2 the P wave is inverted, start to be inverted. In AVR it was inverted, which is a normal P wave axis, inverted P wave, then started to be positive P wave in the low atrial rhythm. Here as well in V1 same, it is inverted, which is normal, inverted, which is normal, then start to be upright in the low atrial rate. And here showing the direction of the pacemaker or the forces for the P axis in the low atrial rhythm. It's coming from this area to upward, or from this area to upward. It will be negative in lead 2 and upright in V1. And here is ECGs for normal sinus rhythm, and you can see P wave before HQRS. This is nodal rhythm, there is no P wave, and there is heart block, as you can see. Sometimes there is dropped beat or non-conducted P waves, atrial flutter, and you can see here the SOTOS appearance of the P waves, and here is atrial fibrillation, which is a irregularity, and you cannot see P waves well determined, and here is ventricular fibrillation. How to calculate the heart rate? To calculate the heart rate, we need first to know what is this ECG paper telling us. At the usual paper speed, 25 millimeter per second. The 1 millimeter equal 0.04 second. 1 millimeter means 1 small square. It equals to 0.04 second, and each 5 millimeter or 5 small square will give us one large square, which will be 0.2 second. So each large square giving 0.2 second and 5 millimeter. There is many ways of how to calculate the heart rate using the ECG, and the easiest way is coming in the next slide. This is one of the ways how to calculate the heart rate using this, and I will let this slide for you to read it to give you 2 ways of how to calculate the heart rate using this, but the next slide is the easier way, so I will explain in the next slide. In this way, as we mentioned, you have to calculate the heart rate. If it is slow, count the number of large divisions or the large square between two RR. So this is R wave and this is R wave. We will count these large squares between these two RR, and then we'll divide it into 300. 300, it means 300 square, large square. That means this is 1 minute. So this will give us the heart rate in 1 minute. Here we have 1, 2, 3, 4, 5, almost 5.8 large square. So we'll divide 300 divided by 5.8 will give us a rate of 52. If this rate is faster, then we can use the small square and divide 1500 divided by the number of the small squares, and this will give us the heart rate accurately. I think this is the best, easy way and the most applicable one to use. Another easy, rough way to calculate the heart rate, if here is R wave, and here is only one large square, so this rate is 300. If two large square from the R to the next R, that means the rate is 150. If there is three large squares between two RR, the rate will be 100. Then if there is 4, it will be 75. If there is 5 squares, it will be 60. If there is 6 squares, it will be 50 heart rate. Please keep in mind that the term bradycardia less than 60 beats per minute and tachycardia more than 100 beats per minute used for adults. According to age, normal resting heart rate per minute recorded on the ECG are as follows. Here for newborn, the mean is 145, and this is a range from 90 to 180. And for 6 months old, the mean is 145, and the range from 105 to 185. And this is a normal range of heart rate according to different ages for until 14 years of age. How to determine QRS axis? Usually we use lead 1 and AVF, and the normal axis, it should be in this direction between 0 and plus 90 degree, and now you can say from minus 30 to plus 90 degrees. This is the normal axis, and then you will find the lead 1 upright or positive R wave in lead 1 and in AVF. Here you can see the left axis deviation. You can see the that lead 1 is positive QRS and lead AVF is negative. So the positive in lead 1 QRS, so it will be in this direction, and lead AVF will be negative, so it will be in this direction. AVF positive here and negative here. So the axis will be between 0 to minus 90. So this is the left axis deviation. And you can remember it by that both QRS are not looking to each other, so that they are on the left axis deviation. For this, lead 1 is negative and lead AVF is positive. So lead 1 is negative, so will be in this area, and AVF is positive, will be in this area. So this is a right axis deviation. And to remember it, look, both the QRS here negative and here positive, so they are looking to each other. If we put it up, the lead 1 and AVF is down, so they will be facing each other or looking to each other. So this is a right axis deviation. And here, as you can see, both are negative, the QRS in lead 1 and AVF. So lead AVF negative will be here in this area, and lead 1 is negative in this area. So this is, as we call it, undetermined axis or the northwest axis. Another way, you can see that among the remaining 4-limb leads, find a lead with an equiphasic QRS complex. You can see a lead with R wave like or equal the S wave in size. In this lead, the QRS axis is perpendicular to the lead with equiphasic QRS complex. As you can see here, the lead 1 is positive, so it will be in this direction, and AVF is positive, will be in this direction. So the axis is in this between 0 and plus 90. And to get the axis to find an equiphasic lead, which is AVL, look here, the R wave equal the S wave in size. So the axis is perpendicular on this AVL. So the direction of the axis will be in this way. And here, as you can see, the mean and the ranges of normal QRS axis by age. The normal QRS axis vary with age. Newborn normally have a right axis deviation compared with the adult standard. By 3 years of age, the QRS axis approach the adult mean value of plus 50 degrees. And here, this table showing the mean and the range of the axis at the different ages. Abnormal QRS axis, the left axis deviation occur in left ventricular hypertrophy and left bundle branch block and left anterior hemiblock. Right axis deviation occurs with the right ventricular hypertrophy and right bundle branch block. Superior axis deviation is present when the S wave is greater than the R wave in AVF, seen in congenital heart disease like endocardial cushion defect and tricuspid atresia. The T wave axis is determined by the same methods used to determine the QRS axis. In normal children, including newborn, the mean T axis is plus 40 degrees, with a range from 0 to 90 degrees, the same as in normal adults. This means that the T wave must be upright in lead 1 and AVF. Intervals. 3 important intervals: the PR interval and QRS duration and QT interval. The duration of P wave is also inspected. The normal PR interval varies with age and heart rate. The PR interval is longer in older individuals with a slower heart rate. And here is a table showing the ranges of the PR interval according to age. Prolongation of the PR interval, like first degree AV block, is seen in myocarditis, digitalis, or guanidine toxicity, certain congenital heart defects like endocardial cushion defect, atrial septal defect, Epstein anomaly, hypokalemia, and otherwise normal heart with a vagal stimulation. Short PR interval is present in WBW, Duchenne muscular dystrophy, Friedreich ataxia, pheochromocytoma, and otherwise normal children. Variable PR interval are seen in the wandering atrial pacemaker, and the Winkie-Bath phenomena, Moffitt type 1, second degree
QRS
block.
duration. It is short in infants and increases with age. The QRS duration is prolonged in ventricular conduction disturbances, which include right bundle branch block, left bundle branch block, WBW pre-excitation, and interventricular block, as seen in hyperkalemia, toxicity of guanidine and procainamide, myocardial fibrosis, and myocardial dysfunction of metabolic or ischemic nature. Ventricular arrhythmias, PVCs, VT implanted ventricular pacemaker also produce wide QRS duration. And here in this table you can see the QRS duration according to age, mean, upper limits of normal in seconds. Here from 0 to 1 month's age, here is a second, 0.05, and you can see the rest of the table showing the normal QRS duration according to age up to the adults. QT interval is a very important interval that we have to be careful regarding it, because it is associated with a very serious arrhythmias or ventricular arrhythmia like torsade de pointes. The QT interval varies primarily with heart rate. The heart rate corrected QT interval is calculated by the use of Bassett formula or the QTC, it will be QT divided by the root square of RR interval. The upper limit of normal QTC is 0.44 seconds in children 6 months and older. The QTC interval is slightly longer in newborn. Causes of long QT, like long QT syndrome, like Jervell-Nielsen syndrome, Romanov-Ward syndrome, hypocalcemia, myocarditis, HCM or hypertrophic cardiomyopathy, dilated cardiomyopathy, head injury, severe malnutrition, drugs as antiarrhythmic agents, antipsychotic medication, antibiotics like ampicillin, erythromycin, trimethoprim sulfamethoxazole, antihistamines like terfenadine. Short QT interval, a sign of digitalis effect or of hypercalcemia. It's also seen with hyperthermia and in short QT syndrome, a familial cause of sudden death with a QTC less than 300 milliseconds. The JT interval, measured from the J point, which is a junction between the S wave and the ST segment, to the end of the T wave. A prolonged JT interval has the same significance as a prolonged QT interval. The JT interval is also expressed as a rate-corrected interval called JTC, using Bassett formula as well. Normal JTC 0.32 plus minus 0.02 seconds, with upper limit of normal 0.34 seconds in normal children and adolescents. The P wave duration and amplitude, which is very important. Normal, the P wave amplitude is less than 3 millimeter, and the duration of P wave is shorter than 0.09 seconds in children and shorter than 0.07 seconds in infants. As you can see here, this is a peaked P wave or a tall P wave, which is, we can call it P pulmonale, which indicates right atrial hypertrophy or enlargement. Here, as you can see, the P wave is wide or prolonged P wave more than 0.1 or 0.10 second, which is associated with left atrial enlargement. Here, as you can see, it is tall peaked P wave and wide or prolonged P wave, which can be seen in biatrial hypertrophy. The QRS amplitude, RS ratio, and abnormal Q waves. The QRS amplitude and RS ratio are important in the diagnosis of ventricular hypertrophy. Because of normal dominance of RV forces in infants and small children, the R wave are taller than S wave. R wave taller than S wave in the right precordial leads, which are V4R, V1, V2. And the S wave are deeper than the R wave in the left precordial leads, V5 and V6 in this age group. The RS ratio is large in the right precordial leads and small in the left precordial leads in infants and small children. The following table is showing the R voltages according to lead and age, mean and upper limit in millimeter. You can see and you can read it in details. It is very, very important and very beneficial table. You can go back to it to revise, which is the normal ages of R wave voltages. This also the RS ratio, mean and upper and lower limits of normal according to age. Here lead V1, V2, V6, and here is age, and here is ranges of the RS ratio. As we said before, the Q wave is the first negative deflection in the QRS complex. The average normal Q wave duration is 0.02 seconds and does not exceed 0.03 seconds. Deep Q wave may be present in ventricular and septal hypertrophy. Deep and wide Q wave are seen in MI or myocardial infarction. The presence of Q wave in the right precordial leads will be in severe RVH and ventricular inversion, or absence of Q wave in the left precordial lead, like a left bundle branch block, and ventricular inversion is abnormal.
And this table is showing the Q wave voltages according to lead and age, mean and upper limit in millimeter. D3, EVF, B5, B6, and here is age. ST segment and T waves. The normal ST segment is isoelectric. Elevation or depression of ST segment up to 1 millimeter is not necessarily abnormal in children. ST segment is judged in relation to PR segment. Tall peaked T waves may be seen in hyperkalemia and LVH. Flat or low T waves may occur normal newborn or with hypothyroidism, hypokalemia, pericarditis, myocarditis,